women are not dying because we don't know what causes them to die. Women are just dying because the society is yet to value their lives.
When a woman in Nigeria finds out she's pregnant, she immediately thinks about two things.
Yeah.
Is it one, is she going to have a baby at the end of this and survive?
Yeah.
Or two, is she going to end up in heaven?
In the Western world, in the high-income countries, women don't die giving birth. And he came to Africa.
Wow.
And within a week, he saw women die. And he was really surprised. How could women die giving birth? It's not a disease. I want a pregnant woman in Nigeria, when she gets pregnant, what she should be thinking is the color of the room she's going to paint for that baby. Not think that she's going to die from this pregnancy.
Hi, everyone. Welcome to Born Into. My name is Isra, Chaker, the CEO of Every Pregnancy, and I'm so glad you're here. As you know, on this podcast, each week we bring you stories of resilience, courage, and hope from around the world about what it is like to help a mom, support her on her journey, or respond to the needs that are happening on the ground. This week's episode is extremely important and very, very special because I am actually here in Kano, Nigeria, where the maternal mortality rate is very high in a country that actually has the highest maternal mortality rate globally. And so we came to the heart of the issue where not only is there saddening statistics, but there's also tremendous hope and potential. And hearing the stories directly from the ground, from the leaders who are changing the way that maternal health is operated on here in Nigeria is one of the best features of this episode. Today, I'm excited to announce our special guest, an amazing obstetrician, researcher, and maternal newborn health advocate from Kano, Nigeria. And she said she will never leave the infamous Professor Hadiza Galandaci. We are joined by her, and I actually met Professor Hadiza through Every Pregnancy last year. And I have heard everyone sing her praises from around the world because she is a true trailblazer in every meaning of the word and what she's been able to do for moms and babies in Nigeria, but also globally, really setting the new trends on how we save their lives, but also help them thrive in the next chapter. Professor Galadanci, welcome to Born Into.
Thank you very much, Isra.
It is so lovely to be here with you. My first time in Nigeria. We had an amazing first day here today.
Actually, it's so lovely to have me at your podcast.
Oh, I'm so excited to have you. Yeah. We're going to call you Prof through this episode. That's like what everyone calls her.
Okay.
I like calling you Prof Hadiza. But if I come up with that, Prof, you are an amazing champion. And I feel like you're incredible work at ACEFAP, which I want you to explain in a little bit, being the director of this incredible institution for excellence, leading research, implementation, direct services, and really training so many people on not just maternal health, but especially maternal health to make sure that we are saving moms' lives here in Nigeria first and foremost, but also replicating that and scaling that in other communities globally. So you're an inspiration. But before we jump into the work that you do in the technical way, what is something about you or what personal story would you want to share with people who are tuning in and hearing you for the first time?
All right. So I'm an obstetrician and a gynecologist, and I come from a family where education is very important. So right from when we're young girls, what our father made sure he got into our head is that the best thing he can give us is education. And once you educate a girl child, then there is no ceiling in front of her. I mean, there is no glass ceiling because she can continue to break that ceiling until she gets, to the highest level she wants. And my dad was, he is my mentor, my inspiration. So he is a professor, but of course, professor in Islamic studies and Arabic language. But I also wanted to be a professor. And that's why even being a doctor, I continued my education until I became a professor in obstetrics and gynecology.
MashaAllah. So there's two Professor Galandacis, two professors.
Actually, we're now getting to 4.
MashaAllah.
Yes.
That's amazing. This is the true narrative that people don't realize is how hard so many people work to be able to change the outcomes for their community. Prof, your story is inspiring. You were telling me a little earlier today that, mashallah, you have 4 very successful children, mashallah. What do your children do?
My first boy is an architect,
Mashallah.
and he's into buildings, and he does great buildings across, Nigeria. My second boy is actually a civil engineer, and he also wants to be a professor. So he will be the fifth professor in our family, hopefully
Mashallah.
one day. And then my third boy is a mechanical engineer, and he's into using his hands and his brain to really have a lot of innovations that will save, women, children, and the rest of the world. And then my last baby, who is actually a girl, the only girl, is actually a doctor.
Mashallah.
And she wants to be like mom,
Yeah.
but she doesn't want to be an obstetrician. But she wants to be a global health expert,
Champion.
but probably ophthalmology or something else. But I don't think she wants to be an obstetrician.
I mean, mashallah, you are a leading example. And what an incredible example for your children to follow. And we wish them success in all of their endeavors. And I especially love that you encourage all of them to follow and pursue their dreams and what it really means. One thing I asked you earlier today, because I know that Prof, mashallah, gets invited to so many places to do training, speaking, and literally connect with the world. I've run into you in Geneva. I've run into you in Dubai. We have so many layovers together and connections and overlaps. But I asked you, would you ever leave Kano today? And your answer was so strong, so quick.
Yeah.
Tell us.
I've had that question over and over and over again. What will take us to take you out of Kano?
Yeah.
Hadiza or Prof or whatever. And I tell them nothing.
Yeah.
Absolutely nothing. Because I feel there's still a lot that my people require in Kano. And I think I can still give more to my people. And if all of us run away from where we are, then who is going to help us?
Yeah.
So I feel it is our responsibility to do as much as we can to really support our community. And your closest community is where you come from. Nigeria is my community, but Kano is my closest community. So my responsibility starts from Kano, and then Nigeria, Africa, and then the world. But Kano is the primary responsibility. So nothing would take me out of Kano.
And I love that because I feel like we live in a time where so many people leave based on a job opportunity, based on additional income, because it's very enticing. You could live anywhere truly and have all the amenities, but you would rather live in your community where things are the hardest for moms and babies. And I think that you are such a inspiring leader. I feel like you're very famous here. Everyone very influential, of course, very well deserved, but everyone will sort of do whatever is needed for Prophet Hadiza. When she asks, everyone comes. And so I feel like all day I've been with a celebrity here, and it's been incredible to watch. Prof, one thing that we talked about, and one thing that I think the listeners really need to understand is that maternal health is not a mystery. I think oftentimes people think, like, what does that really mean? And what can I personally do to help save a mom? We're not talking about really challenging concepts here or things that are hard to understand. So when we say maternal health is not a mystery, what does that mean to you?
Pregnancy is not a disease. Pregnancy is a process whereby a woman, passes through the process of pregnancy and delivery to bring a life into this world. So it's not really a disease. And over time, we've learned what are the real complications that a woman can have when she's pregnant, when she's delivering, or immediately after delivery, that can really be dangerous to even cause her to die.
Absolutely.
The same 5 causes of maternal mortality when I was trained as a medical student are the same 5 causes of maternal death that we still teach our medical students today. It hasn't changed.
Wow. And how many decades?
This is like how many decades I've been.
Literally.
Yeah, I've been an obstetrician for getting to, 30 years.
Wow.
So absolutely nothing has changed. And the interventions we've continued to learn about how we can actually save our mothers. And we have it. And in the Western world, in the high income countries, women don't die giving birth. I've seen a professor that said for 30 years, his practice as an obstetrician in Sweden, he hasn't seen a single woman die.
Wow.
And he came to Africa.
Wow.
And within a week, he saw women die. And he was really surprised. How could women die giving birth? It's not a disease. So that is the question that we need to ask ourselves, why is it that we have the answers to why women are dying and we're still not able to save our women in low middle income countries?
I think that's such a powerful question. And I think today, earlier, and I want to get into the conversation about it, we hosted this incredible roundtable of Muslim leaders and scholars that can really help change the narrative around this. But you presented an incredible slide deck that was so informative. The last slide stood out to me tremendously. It was a famous quote. And if you don't mind sharing, even if it's paraphrasing it, with our listeners, I think this is part of the answer to your question that you just posed on me.
Absolutely. That quote was actually from Professor Mahmoud Fatallah, who is an Egyptian, actually, a professor in obstetrics and gynecology and an Egyptian. He's been an inspiration and mentor to many of us. And he said it very simply, that women are not dying because we don't know what causes them to die. Women are just dying because the society is yet to value their lives.
Wow.
That is just the simple, statement. But it still matters now. Because just as I said, the same causes of death are still the same causes of death. There is no new cause of death. There is no new cause of death. Every single research we do is still hemorrhage, excessive bleeding. It is eclampsia where you have high blood pressure and therefore you fit. It is sepsis where you get infection because you're delivering and you're not in the right environment. You're not using the right instruments and you end up with infection. It is lack of blood, which is anemia. It is obstructed labor, which means you're in labor. You can't deliver this baby. And people say you can deliver it and you stay for ages, for hours trying to deliver this baby until both you and the baby die. Absolutely. So these are the 5 causes and they haven't changed. And we all have intervention for them. So if their lives are worth saving, why can't we ensure these interventions are gotten to every single woman that requires them?
That's such a powerful statement. And that's the truth, because like you said, it's like if we valued women's lives, then this wouldn't happen.
Absolutely.
And I guarantee you, if these things were happening to men, we would not have any male paternal mortality rate in any way, shape, or form. But that really shows you how unfair and how much of sexism and misogyny plays a role in this crisis, almost, and the urgency that we must feel. Prof, thinking and looking back at your career as an obstetrician and in the labor ward, which I know is like one of your favorite places to be, has there ever been a woman that's really stood out to you, or a mom, or a case that you can share with us that has really impacted your career?
Yes. And I think I've said this story a couple of times because it's really something that changed the way I see medicine, the way I see my career. And simply, it's a cousin of mine who I'm very close to. She's had 2 babies with me. And that was she's had actually 3 babies with me. So that was her 4th baby. And she came in routine antenatal care. There was no problem at all. And I was happy with her progress in the pregnancy. Then just towards the end of the pregnancy, she started having raised blood pressure. And I just said one of the complications is raised blood pressure. So I was like, let's treat this blood pressure so that it doesn't become a problem. And we started treating it. And then somehow we weren't succeeding. The blood pressure kept on fluctuating. And the next thing was that she was already term. She was already 39 weeks. So why don't you bring the baby? That's the treatment. That's the normal thing. If the blood pressure, you're having difficulty in addressing or in controlling the blood pressure, then deliver the baby because the baby is fit to be delivered. And therefore we said, okay, let's do an induction. And this was a discussion with her I had with other colleagues that were managing her together. So it wasn't even my own decision. So we had a collective decision. I was like, let's induce her. We've induced many people and there was no problem. So we induced her in the morning. And then by evening, I had a call that she's already in the 2nd stage of labor, which means baby is about to come out. And I said, okay, let me rush, to go and see. There were doctors in front of her. There were nurses that were taking the delivery. And then I just came in and I ran, to the labor ward I wanted to just carry the baby and celebrate with her.
Yeah.
This is a baby that we've gotten. And then I saw blood everywhere. And then I saw them, trying. Everybody was looking, looking worried and trying to give all sorts of drugs. And I was like, what's happening? And they said, she started bleeding immediately. The baby came out. Have you given oxytocin? Yes. Have you given this? Yes. Have you given misoprostol? Yes. I was asking for everything. I was looking for everything, to be given. And they all said yes. And then this woman was still bleeding.
Oh my God.
And then I realized that if I don't do something, this woman would just slip away from her hands. She was just bleeding everywhere.
Oh my
with
God.
blood. And she started looking at me and she was telling me, look after my babies.
Oh my God.
She was already saying that. I know I'm going, look after my babies. And then I was like, let's take this woman to the theater. Let's see what we can do in the theater.
Which is like the operating room.
This is the operating room. And then we rushed. I had an anesthetist. I had 2 anesthetists with me. I had 2 doctors with me. I had all the best of midwives with me. We rushed her to the theater. I did everything I could, even in the theater, to stop this bleeding. This woman wasn't bleeding until the anesthetist told me, you know what? You better take a decision because we're losing this woman. That's exactly what she told me. And I now said, you know what? Can we take this uterus out? Because she was bleeding from a uterus.
Yeah.
Can we remove the womb?
Yeah.
And then they said they should ask the husband because you can't remove, you have consent.
Yeah.
He just wrote consent for laparotomy.
Yeah.
So I now quickly said, can they ask him? And before then, I had many relatives donating blood. I had people, we got like 7 pints of blood, fresh blood. That's what saved us. It's fresh blood. And then they were already bringing the blood into the theater. And then we removed the uterus. And this woman was still alive.
Alhamdulillah.
When we finished the surgery and we moved her to the peri-op, room, I couldn't leave her. This was like around 1 a.m., 2 a.m. at night. I was standing by her because I just wanted to see her breathe in and out. I was just looking at her. I couldn't leave. I couldn't leave
Oh my God.
her for a second. I couldn't leave her for a second. And I was like, if I move, she's going to die.
Wow.
We had given her all the blood. We gave her like 5 pints of blood. That's almost all her blood level, which means she lost almost everything of her blood.
Wow.
I stayed there until in the morning. And after my morning prayers, I also saw her. At that time, she was out of anesthesia. And all she did was to hold my hands.
Oh.
When she saw me in the morning, was just to hold
She probably
my
couldn't
hands.
believe
Yes,
it.
Yes, because she also said she thought she had reached to the other side. In fact, she was hoping to open her eyes and see white angels.
Oh, well, you are a white angel.
Yeah. And that made me to start thinking. I was there. I had the skills. I had the knowledge. I had the expertise. I had all the help I needed. And that was how I solved this woman. How many of our women have that opportunity?
Not many.
Right.
Majority don't.
Not majority don't. So somehow we need to get back and see what can we do to actually prevent women from dying from postpartum hemorrhage. So instead of just, addressing one case at a time and saving one life, can we save thousands and millions of people?
Yeah.
And that's when I started thinking of research as an opportunity. And when I got the opportunity of working to address the problem of postpartum hemorrhage, which is the excessive bleeding, I grabbed it with all my arms.
Yeah.
Maybe I can find a solution that would prevent people like Fatima. That's the name of my cousin.
Oh, I'm so glad Fatima survived. Alhamdulillah.
Yes, can prevent Fatima and have, opportunity of saving many more Fatimas.
Wow.
And that was how I got into research.
Prof. Hadiza, that is like I got goosebumps listening to that story
Yeah.
because I actually thought the outcome was going to be negative.
Yeah.
Because I feel like there are so many more stories
Yeah.
that are horrible outcomes where the mom couldn't be saved
Absolutely.
just because of a slight delay, just because of a medication not being refrigerated,
Exactly.
just because someone not knowing how to put in a balloon tamponade.
Absolutely.
And you, like you said, with all your skill set and all your expertise, still struggled at the end of the day to save her.
Absolutely.
And it is a miracle that she survived that.
Real miracle.
But I really am so grateful that you have a positive story because it shows me, and it hopefully shows all the listeners, that there are solutions, that moms can survive this. Earlier today, the health commissioner, the honorable health commissioner, made a comment. I don't know if you remember it, but it stood out to me significantly. He said, when a woman in Nigeria finds out she's pregnant, she immediately thinks about two things. He said, one, is she going to have a baby at the end of this and survive? Or two, is she going to end up in heaven?
Absolutely.
That literally shook me to my core because I think about my own self when I was pregnant with my son. That never came across my mind. And I can only imagine all the women out there that are living in, industrialized countries that never have to even think that there could be a situation in which that 50% chance, if not higher, they'll end up dying. And so that was significant, I think, to Nigeria. Any reflections on him sharing that and what that really means in terms of the even anxiety women feel being pregnant here?
But that's the truth, Isra. Unfortunately, that's the truth. Unfortunately, when a woman gets pregnant, they say that, one of the countries where you have the highest risk when you become pregnant is actually Nigeria because of the numbers that die. So once she becomes pregnant, it's not only her that is worried that she's going to die. It's her husband, it's her mother, it's her mother-in-law, it's her friends, everybody. Everybody is worried, probably except the healthcare worker. Because if she comes to the healthcare worker, we know that we can do what we can to save her. But every other person around her is worried. Can she really make it to the end? Is she really going to have a baby at the end? Or is she going to die? Or is the baby going to die? Now, and as you said, this is not an issue at all for women in the high income countries. So why should it be in Nigeria?
Why?
So because there's so many, first of all, so many women die. Because there's so many causes of death. Apart from the 5 causes I mentioned at the beginning of this podcast, the 5 major causes, there are other socio-demographic factors that contribute to the death of women in places like Nigeria.
Can you tell me about those?
The first is the delay. If a woman is in labor and you don't take her to a hospital on time, even if she goes, to the best hospital, but it is too late, they can't save her. So a lot of families don't take the decision to get to the facility on time. This could be because 1, they don't have the knowledge. 2, they don't have the funds. Most of our facilities are out of pocket, even though we're doing a lot of interventions to address that. Maybe the hospital is too far. And they're thinking of how do they get to that facility. And somehow, in some places, up to 60% of women deliver at home anyway. So if they have a complication before they can get to the facility, there is a delay. And that delay can be a delay for their lives. The second delay that occurs is that, a woman decides she wants to go to a hospital, or the husband says, look, we've got to go to the hospital. But then, how long is it to the facility? Do they have the money? Because then some of them will have to go and look for the money before they get to the facilities.
Like money for a taxi.
For taxis, for the transport, money for the facility itself. They pay in the facility. They pay in the facility. They pay for card, they pay for drugs, they pay. Some places there is what we call the free maternity care, which means you go without paying. But some of the things are not available. You might still need to go and buy them. So they want to do a cesarean section, but some of the things needed for cesarean section are not available. So you have to go and buy them. So all this now becomes the second delay. So she's still yet to reach the facility because of this, delays. The third delay is actually the delay that happens within the facility. So she gets to the facility, there are not enough health care workers. If there is one doctor, he might be doing one surgery and he might be the only one. He might have 5 complications.
Oh my God.
So he has to do one before he does the other because he's one person.
And
That's
she's
if you're
just
lucky
waiting.
to have. Yes, she's waiting. Or she goes to that first facility and there are no healthcare workers to address her problem. Is the first level of care. So they say, go to the next facility.
Oh my God.
So they get to the next facility. So it might take her ages before she gets finally to come to, for example, myself in a teaching hospital. And then now in the teaching hospital and in other health facilities, you also have delays. You also have delays, So at the end of the day, if a woman has eclampsia in high income country, she'll be saved because she gets straight. First of all, she has the eclampsia in front of a healthcare worker.
Exactly.
She does what she's supposed to do. She sends her to the facility and they take care of her within seconds and done. But in our own facility, she has eclampsia at home. It might take her hours before she can get that health care, that expertise. Hours from decision to get into the facility to the delay within the facility. So this all contributes to the issue of maternal mortality.
Can you imagine if we were able to solve for the delays at any stage? And I know that's what you're actually working on, and you've already had success in many ways on it. And I know through the collaboration with Every Pregnancy in particular on generating and bringing in resources into the work that you're doing. Can you share a bit about how the solutions, because we love on this podcast to talk about, of course, the reality, and then also really direct people towards like, we have the solutions and here's some of them at work.
All right. So I'll tell you 2 solutions, but I want to tell you the solution that has really showed us the light at the end of the tunnel.
I love that.
And that is the emotive intervention. The same delays that actually cause the death of a woman are similar to the delays that actually get a woman with a postpartum hemorrhage to die.
Wow.
All right. So we found 3 reasons why. As I said, somebody with postpartum hemorrhage, which is excessive bleeding, will be saved in high middle income countries and they would die in low middle income countries. So why? We found out 3 reasons. The first reason is that we really delay in making the diagnosis.
Wow.
So a woman is bleeding. We really cannot estimate the amount of blood she's lost because we do a guesswork. We do a visual inspection. We look at the blood on the floor. We look at the blood on her cloth. We look at the blood on the provider's gown, and we say, okay, this is about 300, 400, and once it's less than 500, we don't start treatment. So unfortunately, we're not good in estimation. So a woman will lose 700 mils, but we're still saying it's less than 500. And we showed this with data.
Wow.
We showed that 70% of women that actually have 500 mils of blood loss have not started being given treatment because somebody has decided their blood loss is less than 500.
But by the time she gets to 500, she's already in critical condition.
She's already in critical. She might have lost 2,000 at that time. That's when you realize it's 500 and you start rushing.
Oh my God.
So that was the first delay. The second delay was that, okay, you found out that she's bleeding. And she's bleeding a lot, but you have like 3 different interventions. You give one, you wait for it to work before you give the second. And therefore, by the time you give the 3 interventions you have, it's almost an hour. She would have lost all her blood.
Oh my God.
Then the third delay is that, okay, it hasn't worked, but it's up to 2 hours. Can you now rush her to the theater as I did for Fatima? We didn't wait for 2 hours to take Fatima to the theater. Within minutes when we realized it wasn't stopping, we took her to the theater, and that's why she's alive.
Yeah.
But if you had stayed to continue to try saving her life in the labor ward, we'd have lost her.
Absolutely.
So these 3 delays, we said, how can we address them? So the first delay was, instead of you waiting to estimate blood loss, why don't you have an objective way of knowing that she's lost that blood? With a simple drip. Put a drip and every single blood gets in. And you can actually say, oh no, this woman is losing 300 mils. Don't wait for 500. Start treatment at 300.
So you get ahead of it. So
You're ahead of
the
it.
delay.
You're ahead of it. She doesn't even she doesn't lose up to 500 because we started at 300. A majority of our women don't even have blood when they come to deliver because of anemia.
Yeah.
So 500 in low income country is not the same as 500 lost in high
In the
country,
US, for
yes, it's
example.
not the same.
Yeah.
Because she has more than enough. She can lose 500 and nothing happens. Here, she loses 500, she's already going into shock.
Yeah.
So we said objective assessment. And then the second thing is that don't do one intervention and wait. Do all the three and do a bundle treatment. And that's why we came with the bundle, the motive bundle. Do the massage, the oxytocin, the tranexamic acid, the IV fluids. Give them all within 15 minutes. And then we said, don't wait for 2 hours trying to save this woman.
Yeah.
If you try 15 minutes, it is not working, go to the next stage.
Yeah.
Either send her to another facility, take her to the theater, put a balloon tamponade, but do something. Don't wait again. So that's how we're able to reduce the numbers of women with severe postpartum hemorrhage, which is the loss of 1,000 mil, by 60%.
So you reduced it by 60%,
By 60%.
just by implementing these three
Just
strategies.
this. And you know what, Isra? We didn't innovate any new treatment.
That's
It was
amazing.
the same treatment that we've been using before, but we did a different approach.
I love that.
And that approach is because we considered our situation.
Yeah.
You know, this approach is not important in the US.
Yeah.
It might not be important in the US
or relevant.
because, first of all, the woman has more than enough blood. And
Yeah.
anyway, there will be
Measure it.
one nurse will be looking after her. So
Yeah.
immediately she's losing blood, she'll quickly do something.
Yes.
And she has all the facilities to do everything.
Absolutely.
But for me, in low income country, first of all, the woman will come already having anemia. Two, if I don't start treatment, I don't even have the things in front of me. And I might be the only one looking after so many women. You understand?
Yeah, of
So
course.
you need to start early, identify her early, quickly give all the three interventions, give it at a bundle so that you just stop her and then you can go and do other things and you can save her.
And then be ready to escalate if need be.
And be ready to escalate.
So it's just about
this approach,
preparation.
yes, it's an approach. It's not a new treatment. There is no new treatment in emotive. It's just an approach. And Israel, anywhere you actually implement emotive intervention, no woman dies from
SubhanAllah. That's amazing.
postpartum hemorrhage.
So literally it reduces it completely.
Completely.
It solves it for this reason.
I've had people say this is a magic.
Yeah.
I've had people say this is a magic.
Wow.
It's like you have a tap opening
Wow.
with blood coming and you close the tap.
Wow.
It's that simple.
That's
And
amazing.
it is not expensive. There is nothing too expensive in this.
Of
And you don't
course.
need any new,
Technology.
training for people to do it. You just need to train them on the new approach and it is done.
I feel like this is so easy, I can do it.
Yeah.
And I think that if I was trained in it, anybody could implement it.
Absolutely.
Truly.
So
it's like
doctors-
no barriers to
Yeah.
entry here.
None. Doctors, nurses, midwife, we train everybody. So it's not a doctor that will only save life. Even
Amazing.
a midwife. A midwife has told me that, the training she had is like a magic because she's now saving lives.
Oh, I love that. I love that story, Prof.
Absolutely.
That's incredible. And to think about, so now you've talked about, okay,
Yeah.
here are the solutions,
Yeah.
which I really love. Is there a
Yeah.
second solution you wanted to highlight?
Yes.
Tell
So
me about it.
I wanted to say that, you see, we know what is causing women to die.
Yeah.
We know the interventions.
Yeah.
We haven't been able to get this intervention to every single woman that requires it. Can we now ensure that every single woman that is pregnant gets this intervention? There are many interventions. It's only the PPH I've told you about. We know how to treat eclampsia.
Yeah, you do.
So can we get every single woman that gets eclampsia to get treated? We know how to treat puerperal sepsis. Can we get every woman that has puerperal sepsis to be treated? Can we get every woman that needs antenatal care to have an antenatal package where we make sure we give her MMS? These are multivitamin products that can prevent her from getting anemia. Can we make sure that we prevent preeclampsia by monitoring her blood pressure? Mm-hmm. Can we make sure we give her at least one ultrasound to make sure that her baby is in the right position and is one baby?
And it's growing healthy.
And is growing healthy?
Yeah.
When she comes in labor, can we ensure that there is skilled birth attendant in front of her that can identify when she has a problem and know where to refer her to?
Yeah.
And can we make sure that if she gets eclampsia, we treat her, we know the treatment. If she gets PPH, we treat her because we know the treatment. We make sure we give her antibiotics so she doesn't get puerperal sepsis. Can we make sure that after delivery, we make sure that she puts that baby to breast immediately so that we can have, you know,
Kangaroo
babies
mother
that,
care.
yes, the babies can survive. Give kangaroo mother care.
Yeah.
Make sure we have delayed cut clamping. Can we make sure that every woman that has a cesarean section or needs a cesarean section is given quality cesarean section?
Absolutely.
So if we're able to do all this, at least we will address the issue of the health system.
But this feels like the bare minimum, Prof. Like you're listing out these things and I'm like, this feels like bare minimum.
They look very bare minimum to you, but they are not to us.
Wow.
Do you have the infrastructure?
Yeah.
Do you have the human resource? Do you have the training that this healthcare workers require? Do you have the resources in terms of consumables and drugs?
Yeah.
Do you have, when I say infrastructure, you're talking about water, you're talking about light, you're talking about all this basic
Like we're even talking about basic things, electricity
basic thing,
and water.
everything.
So these are the challenges to be able to implement these things.
Absolutely. And there's one more challenge, which is actually in the community. People need to access the facility. So if people don't get to the facility, I can't save them.
No, you
at their
can't.
homes.
Nobody can.
All right. So they've got to utilize the health facility. If they don't utilize the health facility, then we get the services to them. Because that is something we're thinking of.
This is innovative.
This is innovative.
You're flipping the switch.
Yes.
So how are we going to do that?
So what we need to do is we need skilled birth attendant.
I love that.
So can we get this skilled birth attendant to take the delivery of a woman that has a low risk at home?
I love that.
But she has to be skilled.
Yeah.
Is not somebody that is not skilled, because then if it's not skilled, she will not be able to identify risk. And then, of course, a skilled birth attendant, you have to link her up with a referral system.
Exactly.
So that if she finds a complication, she knows where to go to. And
I
she
think
can
that's
take her
critical
to
information.
Yes, she has to take her to the facility.
That's critical information, and all of it needs to be prepared.
Absolutely. So if a woman is low risk, in some states, as I said, 80% of our women deliver at home. 80.
Wow.
80%. They don't
be
go
higher than a lot of other countries.
They don't go to the facility to deliver. We've been pushing them to the facility to deliver. They're not going.
Yeah.
So why don't we look for an innovation? For those that are low risk, find out, get them to have at least one antenatal clinic and screen them. If they are high risk, insist they get to the facility. You reduce the burden even in the facility. If they are low risk, then send a healthcare provider to take that delivery. And healthcare providers, community health workers, are allowed to take a delivery. And they're roaming around in our streets not having work to do.
Wow.
So we can actually engage them. That is a study we're trying to do. And we're going to do a research to prove if this will work. It is a research. So we want to see whether it will work. If it works, it's going to be a game
changer. Look
Absolutely.
at that. Said same word.
Yeah.
I mean, Prof, I love your passion and you have everything we need. This is like the guidebook. If anyone wants to know the guide to save moms and babies' lives, watch this episode, download it, share it with people. But I have a question for you. Now, we have some social issues and cultural issues around this too, right? So it's not just about the infrastructure and systems, which are really important, but it's also about the community and families, even in the family unit, recognizing that we all have a role to play.
Absolutely.
So what are some of the challenges that you have identified in the family unit or the societal level that also needs to be addressed and should really be named in this conversation?
All right. So decision making. Yeah. Decision making. Actually, you see, for a woman to decide if she's having a complication or if she wants to go to the hospital to get to the facility, she has to make that decision. Now, in our community, that decision making is not by that woman alone.
Yeah.
So many other people take that decision. Importantly, her husband.
Yeah.
So supposing the husband is not in town, supposing the husband cannot be reached, how do you now ensure that woman gets access to when she needs help?
So how do you do that?
Decision making is very important. Sometimes it's even the mother-in-laws that take decision.
Wow.
Sometimes it's the mother-in-laws that take decision. So I think it is very important that part of creating awareness and educating our community is the importance that a woman should be given education so that she can take a decision. A woman that is not educated cannot decide for her. She can't decide for herself. She can't decide for the family. She can't decide for her children.
Absolutely.
But an educated woman will surely be able to take a decision, whether her husband is there or her husband is not there. She will know what she will do, so that she can access him, to even ask him for permission. An educated woman will sit down waiting for somebody to do it. So really, I feel it is very important. Girl-child education is one way to tackle the issue of decision-making, plus the community awareness. Once you educate a girl child, you have really given her the opportunity to save herself, save her family, and save the community.
I love that. And even just encouraging her to have her own agency in this.
Absolutely.
Like, you know your body better than anyone else knows your body.
Absolutely.
And I kept thinking about, there are so many Black women in particular who are told that, that there's something wrong with them, that there's something that they're being ignored for their issues.
Exactly.
So I can imagine that even a woman delivering in Nigeria being told, oh, actually your body is yours.
Exactly.
And you should ring the alarm if you feel like something is going wrong. And then also being educated on what it is that could go wrong.
Yeah.
So there's a responsibility here also on women, I think. Like, if you don't have the education, find the ways to get those resources. And I know that you are doing a lot of that, also community building and education piece.
Yeah.
Prof, today we talked a lot about earlier the role of the Muslim community and Muslim leadership. I think people don't recognize that obviously the context around maternal health is different and how it's applied and how it's approached depending on different countries, but also even as different cities.
Exactly.
Right. And so I know Nigeria has a lot of different sects, even within the Muslim community.
Yeah.
And that there's very tribal ways of approaching this issue.
Absolutely.
So if you're trying to build coalition and trying to get stakeholder engagement for tackling maternal mortality, which affects all women, right? Every sect, every religion, every identity, how do you go about doing it in a place as complicated in some ways as Nigeria? And what have we been working on together on this?
Yeah, so you've seen it today.
Yeah.
We're able to bring all the different sects, Islamic sects, into our meeting, because you needed to have all their buy-in.
Yeah.
And I was amazed with, the agreement by all of them.
Literally all of them.
Literally all of them. All of them believed, the importance of saving life, preserving life. All right. Sheikh Mustafa reminded us of the 5, you call it the maqasid?
Yeah, the maqasid of our faith.
Maqasid,
the laws of our sharia, essentially.
The laws of sharia.
Yeah.
He said faith.
Yeah.
He said preserving life.
Yeah.
He said preserving wealth. He said lineage. And then he said mental health.
Yep.
And he said from number 2 to number 3 is actually all related to saving women and children.
Absolutely.
If you preserve a life, if you save a life, then it's like you're saving the nation.
Yeah.
And we know the importance of giving.
Absolutely.
In Islam. Zakat, wakab, sadaqah, we know what it is. Your neighbors, you should give them everything. So when we now mention that every member of and all the sects in Nigeria were like, yes, we need to mobilize funding, mobilize whether it's through zakat, whether it's through wakab, whether it's through sadaqah, to be able to actually mobilize money for resources for our women and children.
Absolutely.
And yes, and I mean, the global funding is dwindling.
Absolutely.
We know that, we're really getting to an era where there is no more donation. There is no more donor funding, especially from big, countries. So somehow we need to wake up from the sleep. We need to realize that we need to generate funding from ourselves.
Exactly. That our community will be the only community to save us. And we often talk about challenging the status quo.
Yeah.
And I feel like every pregnancy exists to challenge every status quo.
Yeah.
Dependency on the wrong funding models, working in silos and really breaking through that. And also reaching moms and babies who need the care the most. And it's something, I was nervous a little bit coming in today's meeting because I wasn't sure what to expect.
Yeah.
This is a new type of concept. It's foreign to say all of a sudden we're just going to work all together and everyone's ego is on the side and everyone's identities is not important to the mission, because you should be using your identities to help fuel your commitment, but don't let it be a barrier to working together. And Prof, I think that you really started us off in a way that painted the issue as one that affects all Nigerians. And it was really powerful. And I could see that the room was resonating. And by the way, the room was majority men. Yeah. And it was majority people who were from Islamic background, Islamic scholars and clerics. And every single one of them, like you said, agreed, but also I felt were committed to taking action. And so one of the things of every pregnancy is really working with the Nigerian community, having them lead and us support and amplify, especially because you are already implementing the solutions.
Absolutely.
You already know what the needs are on the ground, and we're just here to amplify that. So can you talk a little bit more about the importance of having stakeholders like the Muslim leadership community involved to be able to really solve maternal mortality here in Kano, but at Nigeria at large?
As I said in that presentation, every single one of us is a stakeholder. And maternal mortality has, a whole lot of stakeholders. You have the women, you have the men, you have the policymakers, you have the healthcare providers, but importantly, you also have the religious leaders, the traditional leaders, and our, community leaders.
Yeah.
These are people that when they talk, people listen.
Yeah.
People listen to them. So if a religious leader comes up and say that, these are the rules of Sharia to preserve life, and therefore you should give. And anyway, in the Quran and in the Sunnah, these are the hadith and the surahs that talked about the importance of giving. Therefore, come out and give for the sake of women and children so that we can save our own women and children. These are women and children of the society. They're not women and children of somebody else. They are our own mothers, our own sisters, our own cousins, our own daughters that are dying. So if we come out, if they speak, people will listen.
I love that.
People will listen.
And we're really tackling that.
Once you say it is from the Quran and it's from the Sunnah, our people are ready to follow. And that is why it is important for us to have their buy-in. If we're able to get their buy-in, then we will be able to actually mobilize resources for our women and children. And at the end of the day, they are the trusted people.
Yeah.
So people will trust them. So that if you give, you know that they are given and your funds are going to be used for what they said they're going to use them for. So it is very important that we get their buy-in. But as I said, all other stakeholders are also very important. And as you can see in that hall, we had other stakeholders as well.
Yeah, I think being able to build this ecosystem where you really have the religious stakeholders, the government stakeholders, the traditional stakeholders, the NGO stakeholders, and even those who are the healthcare providers, and then the champions overall. So, Prof. Hadiza, where would you like to see maternal health in a year from now?
Well, I don't want to say that I want to see no woman die from pregnancy-related complications, pregnancy and delivery in 1 year. I know that is not
impossible.
That's impossible. But I really want to see, that women have access to quality antenatal care, quality intrapartum care, and quality postpartum care. And our women are able to access these services. If they are not able to access these services get to them at home, so that at the end of the day, we can reduce the unacceptable numbers of women that die. I want a pregnant woman in Nigeria, when she gets pregnant, what she should be thinking is the color of the room she's going to paint for that baby, the pants she's going to put for this baby, the clothing she's going to put for this baby, the shovel she's going to use to bundle this baby, not think that she's going to die from this pregnancy, or not think that probably her baby will not survive the delivery and she might not have this baby. That's what I want our pregnant women in Nigeria to have at the end of the day.
That's so powerfully said. For those listening to this and thinking, wow, Prof. Hadiza just inspired me, motivated me, how can they get involved and how can they take action? What would you tell them?
I think everybody can contribute to reducing maternal mortality. Every single person. And I mean it, every single person. If you're a husband, then you ensure that your wife gets quality antenatal care and delivers in a health facility. If you're a young girl, you ensure that you encourage your parents to give you the education so that at the end of the day, you can save your life, save your family's life. If you're a healthcare provider, make sure that you learn all the skills to save, women. If you are a policy maker, make sure you have all the policies that will save our women, and make sure that you provide the enabling environment for these policies to be implemented. If you are government, part of the policy makers, that make sure that the policies are there, and of course you provide the enabling environment. Community leaders, religious leaders, make sure you continue to create awareness on the importance of the health of women and children, and let us see how collectively we can actually come together to end the numbers of women and children that die.
So incredibly powerfully said. The last thing I'll ask you is almost to finish the sentence. Are you ready? Every mother should.
Every mother should deliver safely. Every mother should have a safe pregnancy and a safe delivery.
I love that. Every baby should.
Every baby should have the opportunity of surviving and thriving.
I love that. Every community should.
Every community should ensure that women in that community get safe pregnancy, safe delivery, and safe postpartum care.
And every Nigerian should.
Every Nigerian should make sure that every single pregnant Nigerian woman ends up with a safe pregnancy and delivery.
And with that, what a beautiful way to end this recording for this podcast. Thank you, Professor Hadiza, for being on our incredible show, Born Into, bringing your incredible insights, your passion, your commitments, your expertise, and your storytelling to really help people understand the true crises on the ground in Nigeria, but even globally. And also recognize the solutions that are here, that are affordable, and that can be implemented with very little training. We are honored to be here with you and in partnership with Every Pregnancy and ACEFAP. If you want to learn more about Professor Hadiza's work, please look at the notes on this episode. Follow her on social media. Follow the incredible work ACEFAP is doing and contribute to support them. Thank you so much for being on Born Into. Subscribe to this podcast. Share it with your friends. Follow more on Every Pregnancy social channels, as well as our website, everypregnancy.org. Thank you all so much for tuning into Born Into, live from Kano, Nigeria. We'll talk soon.